This episode of Scoliosis Dialogues is presented by Medtronic as a part of the sponsored content series.
Thanks everyone for joining us tonight for this podcast. Thanks to Medtronic for helping support this podcast for the Scoliosis Research Society. My name is Pat Segru. I'm a neurosurgeon as part of the Advocate Aurora system just outside Chicago. I'm joined by Dan Hedequist and Joe Osorio. I'll let them introduce themselves in just a minute. What we're going to talk about tonight is specifically using technology and patient-specific planning for how we've used that to help enhance how we're able to take care of patients and enhance our own practices. So we're going to focus really on three different technologies, specifically UNiD and the UNiD hub that goes with the patient-specific rod. We're going to talk about robotics in spine surgery, specifically Mazor, but also the use of 2D long film with the O-arm. So before I have the other guys introduce themselves, in terms of full disclosure, I do some consulting work for both Medtronic and NuVasive, as well as some advisory roles. And I do some consulting and design work for Orthofix as well. So I'll turn it over to Dan to introduce himself, and we'll go from there.
Hi, Pat. This is Dan Hedequist. I'm a surgeon at Boston Children's Hospital. I've been there for about 21 years, and I look forward to talking to you and Joe tonight about some of the enabling technologies we've been allowed to use at Boston Children's.
Excellent. My name is Joe Osorio, and I'm a neurosurgeon out of San Diego. I primarily just treat adult patients. I'm the director of complex deformity and spinal pathologies, neoplastic pathologies. My disclosures are with Medtronic, DePuy, and Alphatec. I do consulting for all three of those. And my history with the UNiD technology, I've been using the technology since 2016. I've been using it here in San Diego for the last 2 years. And the Mazor, my experience dates back to 2018. And we're in stages of acquiring our 2D long film, which should be installed this month.
Great. Thank you guys both for joining us tonight. I think it's going to be a great discussion. So, first and foremost, I think the way this structures best to discuss these things is to kind of look at it in terms of first preoperative planning, and then intraoperative execution, and then finally intraoperative verification that we achieve the goal of what we set out to do, right? So, as we go, I'll ask you guys to describe the different technologies and how you use them. Perhaps for somebody who has experience, or perhaps somebody who has no real experience with these technologies at all. So, but I want to do it in the context of how we approach the problems that we're faced with as surgeons. So, first, from a standpoint of preoperative plan. So from my standpoint, I tend to be a big planner, right? So I like to really sit down with all the films, my evaluation of the patient for my clinic note, and really kind of go through it and come up with a plan of what I plan to do in surgery. I've got radiographic goals, I've got neurologic goals in terms of decompression here or there, whatever it may be. And I use oftentimes the Mazor X-Align planning software to do that, right? I really like the ability to kind of basically plan every screw, plan my correction, and it allows me to come up with basically a line-by-line plan of what we're going to do in the OR. Right? I look at it as I want to do a lot of the big intellectual work before I get to surgery, and then when I'm in surgery, I can simply execute my plan, and then of course verify that I did it correctly. So Dan, I'll ask you first. How do you go about evaluating and planning for your case?
Thanks, Pat. I think I've been lucky enough to sort of plan some of the cases on Mazor preoperatively with the software, and some more intraoperatively. There's the two ways of registration for the Mazor now is a preoperative CT and then CT to fluoroscan. That's one way to register. And the other way to register in my practice has been an intraoperative O-arm, and then after the O-arm, looking at your pedicle anatomy, your trajectories, and then planning. And for me, that was, I think, pretty important because I didn't want, as we adopted the technology about 2 years ago, we didn't want it to be too disruptive. So I didn't want to take my AIS population where I routinely never get CT scans and start CT scanning patients that I hadn't routinely done. But we also have a fair amount of congenital patients or high-grade spondylolisthesis patients or tumor patients that have routine CTs. So, and the patients that have had routine CTs, we've used that as a way to register. And I think it's been really good to really look at their pedicle anatomy, look at your trajectories, plan your cascade of screws and do that preoperatively. Use that platform to educate the residents and fellows about pedicle screw placement and different thought processes. But it's also been helpful. The other way to register is just intraoperative O-arm, especially in the AIS population, and sort of learning maybe what pedicles I thought were going to be impossible that now are much more possible to do. But also sometimes looking at pedicles and say, maybe I don't need to put a screw here because the anatomy is prohibitive. So that's been pretty eye-opening on patients that otherwise we wouldn't have a CT scan on and may struggle to do it freehand.
Sure. I think we'll touch on a couple of those different points in just a sec. But Joe, how about you in terms of how you approach a case and how you then plan it out so you know what to do in the OR?
Yeah, I like you. I'm also a planner. I think in the adult space, I have the advantage that I do many times and obtaining a CT scan before surgery. So as it relates to the Mazor, I do use a CT to fluoro registration. I'm using that CT scan that's obtained before surgery. For me, in terms of the planning as it relates to the UNID technology, it starts at the time that the patient comes to their first visit. They obtain a standing x-ray before I see them. Those x-rays are measured right at their first clinic visit. That allows me to start tackling the problem. And there's times where I'm between plans. I'm trying to decide, am I going to do an upper thoracic to ilium reconstruction, or will it be a lower thoracic to ilium reconstruction? Will it be a 3-column osteotomy, or will I spread my correction over many levels and do lower grade osteotomies in order to minimize the invasiveness? I think one of the values in planning with the UNID hub is that I'm able to come up with more than just one plan and see what that desired outcome is. As it relates to planning before surgery, when I look at the plan, I'm almost getting a glimpse into what the postoperative x-ray is going to be. And so in that sense, I really spend most of my time like you before surgery. So I do the heavy lifting at that time so that at the time of surgery, it really is just about executing the plan.
I think one interesting thing that you mentioned there is the idea of having multiple plans, right? So, I mean, how has the use of the UNID hub and planning a patient-specific rod changed how you do things, right? The idea of having multiple plans and kind of looking at it to see what's going to optimize that outcome really seems pretty impressive, right? So explain a little bit of what UNID really is and how it creates those multiple plans and how it influences what you're going to do.
When we think about UNID, what it really is it's taking essentially predictive analytics or just using modern computer algorithms similar to the way we do in our daily life through our phones, through our apps, and it's taking previous cases and it takes your plan and it tries to predict that proximal segment. And how that compensation will ultimately look for a desired outcome. I think what surprised me the most through using this technology is that if I am between two different plans and one is more invasive versus less invasive, the times where I've been most surprised is where I'm able to achieve an outcome by doing less than I would have potentially anticipated without a plan. And so those are times where I feel like I may have expected that I needed, let's say, a 3-column osteotomy to get a correction, but then through looking through the plan and then understanding my own outcomes, that's another important piece, is that through the analytics, you're going to get a sense as to what your actual outcomes are so that when you're planning these cases, the more you use the technology so that you can plan appropriately. And so I'm finding myself doing less than expected at times.
Well, I wanted to follow up on one more thing that Joe said, though, Patrick, and that is, I think, patient-related outcomes are massively important, but one thing that's really helpful, I think, with the UNID hub is just your own surgeon dashboarding, right? How many times did you think you could create a plan like Joe said? And then the advantage of the UNID platform is you can look at your post-operative films. Those could be analyzed by the computer and you're given your real objective measurements, right? Because I don't think we probably all do that maybe as much as we think we do. That dashboard, I think, is really helpful to sort of, especially in the pediatric space, when we talk about restoring thoracic kyphosis with coronal plane deformity, when we talk about doing selective fusions, as you collect these patients over time, to have a much more objective sort of platform to collect your cases and to follow them over time.
Other thing that I think is important to bring up is that, all of us have, busy deformity practices, and we've trained in different ways, and we've trained, each of us from some great surgeons. But as we develop and grow in our practices and basically incorporate new technology, undoubtedly there's barriers to that, right? It's stuff we didn't learn before. We didn't learn it in training. How do you guys overcome some of those barriers? Or Dan?
Yeah, I think, one of the novel things about Mazor for me was I hadn't done navigation as well when I first started Mazor. And so, the Mazor X Stealth now is robotics with navigation. And so I came into this as sort of a real rookie, even though I'd been in practice 20 years. One thing was helpful. I had another group of surgeons that had really adopted the technology at the same time and had the chance through Medtronic to work with them as far as discussing our workflows on a pretty regular basis. And I think it's opened my mind to how many surgeons are using enabling technology, but really when you really talk to other surgeons, how much you can gain by their experience. And whether it's even a peds guy, listen to adult people, how they do things, how they plan, the most helpful and eye-opening thing. I think there's a community that's now just adopted enabling technology.
Joe, how about you?
Yeah, I think it's interesting that you do end up changing your practice with the technology to some degree and learning from it. And that's, again, where I've used the analytic portion to look at my outcomes to see whether I'm moving in the right direction or not. The Mazor, I know for me, initially, my biggest hangup in terms of adopting it for larger deformity cases was placing the screws before I had done my osteotomy work. And so here's a way that I didn't learn, let's say, before coming into practice, but I've adopted the technology. I've embraced sort of the limitations that it has, because you would like to place screws with the exact intraoperative CT to fluoro registration without disrupting and correcting too much before you've placed your screws. But I'm going along and utilizing the latest advances through that technology to make it work within my workflow.
I think it's a nice segue to the next kind of component of this. So, I want to talk a little bit about how you get your plan to the OR, but also then, the things that you first encountered that slowed down your workflow, and specifically touch on the idea of how you make a new technique or a new technology work in your own workflow, and just basically how you kind of overcome those hurdles. Joe, how about you?
I would say one of the initial hurdles was through UNIT, I would say, was the correction for scoliosis patients, at least in my practice. I noticed that the pre-bent rods, or the patient-specific rods, were incredibly powerful in correcting patients in the sagittal plane and getting that sagittal correction that was desired. But I had to understand how to utilize that technology as it related to coronal plane deformities. And so what I found myself there was understanding sort of the rod length variability. So you still have to rely on your fundamental correction techniques in order to get that same desired outcome. You just have the benefit of the planning, and then intraoperatively, you have a tool to get you there a little quicker and a little easier.
Dan, how about you?
Yeah, I mean, I think the workflow hasn't been prohibitive, and I think, like all surgeons, the more cases you do, the better you get. I mean, I think we've done 175 deformity cases the last 2 years, and how I do things now is different than how I did it when I started. And it's both things that have to do with efficiency and how, if you're going to run the O-arm, time of things like bringing the O-arm in. Or I've used to prepare my docking point for my drill much differently 70 cases ago. Now that there's a Mazor high-speed Midas that's navigated, it's totally changed that workflow. So I think you just have to go in with the expectations that you're going to learn from every case that you do. And then I think sharing that knowledge and sharing conversations with other surgeons doing the same things has been probably the most helpful thing for workflow for me.
Joe, from your perspective, with regard to Mazor or Unit, what are the kind of, 2 or 3 pearls you'd give to somebody who's just kind of starting out in this?
I would say for the Mazor, the same thing in terms of talking to the community. I changed my practice. I used to drill, tap, place a screw all in one, and now I do the same thing that you guys are doing. I will Midas burr every hole first, because I've noticed that even the tap in really good bone could cause a shift. And so I'll drill all the holes first and then tap, and then I would go back and potentially do some bony work and then re-register. I think understanding the foundation of how the Mazor is registered to the patient, it has to understand where the arm is in space to the actual body. But re-registering after you've done those initial scans, which may take 5 to 10 minutes, you only need to do 2 x-rays in order to re-register, because it already has that foundation established. And so I find that is incredibly cumbersome, where before, not understanding the technology, I thought I was going to waste a significant amount of time re-registering, but it didn't take as long as I expected. In terms of the Unit technology, many times when I first started, I would plan a case perfectly. And that may mean that my UIV I felt was not going to change, but there were some of those cases where I was between 1 or 2 levels in terms of stopping. If I was going to stop at, let's say, T4 versus T3, and I was still thinking about the case, I now order those rods for a longer construct, and then so that I don't get caught in a case where my rod is too short. So I might plan the extra level of UIV so I can cut down my rod, so I don't have the option of losing out on using that rod during the case.
How about planning for a upper thoracic UIV versus a lower thoracic UIV? Is that something that is possible? Do you do that very often in case something intraoperatively changes, or you kind of know ahead of time going in and don't need to necessarily make it that much longer?
Yeah, I think it's not that much longer. I think it's usually one level at most that I'm between. I'm trying to figure out whether I'm going to go upper thoracic versus lower thoracic, usually in the planning phase, when I'm sending in those multiple plans and I'm trying to understand for myself, because the Unit plan is based off an upright x-ray. And one of the things that the surgeon still has to think about is how stiff or how much compensation the patient will have. I still get a supine x-ray in order to understand that. And if I don't anticipate that there will be that much change, I'll chat back and forth with the Unit engineer to say, maybe we're factoring in too much compensation, and that'll play into the plan. So although the Unit technology, they will feed back an initial plan, there's always an opportunity to adapt that plan. And you're still going to use your surgeon intuition or your experience from other scans in order to verify and validate that ultimate plan that you decide on.
Joe, to that point, from your standpoint, more specifically with Unit, or for that matter, for the Mazor system, what have you found of things that you can do that perhaps before using it you couldn't do?
I would say that, one of the ways that I've used the Mazor, at least in adult deformity cases, I'll minimize many times my dissection distally. And so I'll leverage putting in those screws more in a minimally invasive way has minimized how much invasiveness I have at the time of surgery. I would say that reliability component is really important. We know what we're going to use going into the case, even as it relates to the inner body. So the planning, I also use the planning not just in terms of getting a desired rod that's pre-bent, but the rep in the room, if we're putting an inner body in, he knows exactly which lordosis cage I want to put in. And then it's just a matter of which size lordosis cage of that same lordosis will it be. And so I think in terms of efficiency, my scrub, my rep in the room, everybody is on the same page because we're going off that same game plan. And so in that sense, it's been very helpful.
I agree wholeheartedly on the efficiency part of it. Just having a plan and knowing kind of what you're going to use in surgery, and knowing that, that you can execute it efficiently, it just makes the whole day so much easier. Everybody knows you're on the same page, you know what's coming next, and absolutely makes the day much more enjoyable. With that said, right, so we talked a lot about coming up with a plan, and then ultimately how we execute that plan. And we're, when the workflow works and we're happy with it, we got a great plan, great. But what about actually making sure that you did what you set out to do, right? So, from my perspective, 2D long film has been a huge piece of that. Certainly, forever we've gotten intraoperative X-rays, long cassette films. But anybody who's done that knows what a challenge that can be sometimes. It depends who the X-ray tech is. It depends on which machine they bring in. It depends on how they position the plate and all these things. Even as we evolved to the digital plate that allowed you to at least look at it in surgery and say, hey, that's off, move your machine, move the plate, whatever it is, it always added just so much time, right? And so, my, utilization then of 2D long film has been, an absolute game changer from my perspective. You basically have to just select the start, select the finish, and you just click the button and it does all the work, right? And stitches it all together. So, and it's not only the ease of use, but it's incredibly high quality image, at least in my experience, compared to either digital or other long cassette film. So personally, I think it's been a huge difference for me to make sure I actually did what I set out to do. But I think it's, the idea of getting an X-ray in surgery can't be overemphasized. Everybody should be doing that. I hope everybody is. And to do it in this fashion is quite helpful. So, Dan, can you speak to your use of 2D long film, or for that matter, how you verify in surgery that you did what you set out to do?
Yeah, I think that's really important. As you well know, to really find out if your screws are where they need to be, you need a CT scan, right? Which isn't reasonable for the vast majority of patients. But to be able to get a 2D O-arm long film, and then you can compare that against your Mazor plan, and you can mirror the images together, and you can really over time look and see exactly that your screws are matching the cascade with what you're doing. And it's really just it's a great confirmatory thing, like you say, to confirm that your technique and what you did really matches the plan, right? Because if the plan of your Mazor was based on either a CT or an intraoperative O-arm, and those screws are in the pedicle by proxy because you plan them, and then you match that to your 2D film, it just gives you another confirmatory step that the processes that you're following are actually successful.
Sure. Joe, how about you?
Yeah, I'm using exactly the plan to compare against my intraoperative X-ray. And so when I get that long cassette X-ray, I'm measuring that scan and I'm comparing it to the plan that I came up with preoperatively. And if there's a target goal that I was really aiming for, that was the crux of the operation, I'll be measuring that exact measurement and seeing what it's like intraoperatively before I leave the room to know if I've executed my plan. The efficiency in using the O-arm is exactly the reason why we ordered a 2D, which will be on the O-arm system here at UCSD, because it's exactly the efficiency that you talked about, Pat, or the inefficiencies with regular cassette X-rays in the tech, which I'm looking forward to mitigating by using the O-arm to get the long cassette scoliosis film.
Joe, from your perspective, the use of a unit rod, right? I mean, I think you've got the most experience of the three of us with using, the unit rod that's patient specific. What are some of the things that you're doing to try and so that X-ray does look like the what you planned, to make sure it really gets there, right? So what do you do in surgery, and then how do you verify it on that long film?
I think there's a couple things that I'm utilizing. I think we can't forget that the rod is essentially a template for the surgeon. And so if you have an apex of your deformity and you are loosening the spine to a certain degree, are you at your desired outcome where you're ready to place the rod? You can quickly pull that rod from the back table, lay it against the spine, and know right away, just by looking at the rod and the spine, whether you're close or you're not, or whether you expect to be able to move the spine to the rod. My technique is to loosen the spine as much as possible and actually move the spine to the rod through reduction screws. And so I use many reduction screws throughout my construct, and I distribute that load across many levels, and I move that deformity slowly because I really am trusting the rod as I'm moving the spine. I think many times if you're doing several low-grade osteotomies through the lumbar spine, you'll notice that the patient will sag. And so through the reduction screws, I'm pulling up and getting that exact desired lordosis that was planned for with that rod. And so that's really probably the way that I'm utilizing it the most.
I think that's a lot of great pearls on how to do that. So in terms of, how we use this image, these imaging techniques intraoperatively, we then want to move kind of to the post-op setting. So one of the big things that we've talked about is talking to other surgeons, looking at our own results, looking at the data. One of the, the advantages of being part of the Unit Hub is that it has so much data in it, right? Everybody's talking about data. Everybody wants to have data, and how you use a lot of this data and really kind of be honest with ourselves and be part of registries to kind of look at our own results. How are you using a lot of the intraoperative and postoperative data that you have to then kind of influence your own practice?
I think just looking at sort of your plan and just simple things in AIS, right? If they're hypokyphotic and I'm trying to restore some thoracic kyphosis, right? How do I plan my rod bend then? What do I tell the engineers on the unit platform what I want? And is that like if they have 5 degrees of thoracic kyphosis and I want to take them to 25 degrees of thoracic kyphosis, what was the plan I did on my unit? And then what was my result? And that's going to take, even individual data is going to take time to work that out. So I think that's important. But I think it just, right now, as an individual, the limited data we have, even if you're a busy surgeon, it just gives you a chance to really objectively study it, right? And then the bigger pictures is going to be, like you said, as you share data, as people share data on the hub and that gets worked out. But in the short term, just your own individual I think it's just a much more reliable thing rather than maybe measuring your COBs afterwards versus just saying, oh, it looks pretty good. You can really measure, and did I really do what I thought I was going to do? And if I didn't, is it the technology? Was it my rod stiffness, my rod bend, lack of osteotomies? And then really just, it makes you just think about your next case a little bit more.
Perfectly put. Joe, how about your thoughts?
The unit platform, I think one of the things that's very unique and powerful is that as you start to accrue your cases, one of the goals is to sit down with the engineers on a quarterly basis and really analyze your outcomes. So on your phone, you have the ability to look at all your cases and just get a quick and dirty sort of outcome analysis as it relates to how well you're correcting, let's say, sagittal corrections, or looking at your PI-LL mismatch, what it was preoperatively. It'll give you a graph preoperatively, postoperatively, and then the postoperative time points wherever you collect your normal x-rays. But then you have the opportunity you do it initially after 10 cases, but then quarterly thereafter, you can sit down with the engineers and look at it in more detail. You can look at your osteotomies. What is it that I'm actually getting through my osteotomies in the lumbar spine, so that when the engineer goes to calculate that plan going forward, they're actually putting together a realistic measurement for you as a surgeon. I know initially when I started, we were planning thoracic correction osteotomies at the same exact correction, regardless of where we were in the thoracic spine. And I noticed in my cases, I was getting less in the upper thoracic spine than I was getting through the lower thoracic spine. That's something that we ended up changing and that we learned over time by looking at my cases.
That's great. That's great. I think, probably the one thing you take home from a lot of this, is the use of different technologies to try and, not only plan better, but execute what we set out to do, and then verify that we did that, right? And then just be honest with ourselves going forward after that. All right. Well, thanks everyone for listening to the podcast. And again, thanks to Medtronic for helping support this podcast for the Scoliosis Research Society.